There are a number of things that people can do to meet the breathing challenges.
He could stay on this and use it for a long time or for forever. You know, we're willing to give that, a try.
I have, for instance, a patient who is just a tremendous advocate. He lives now almost all the time with his BiPAP machine, but he's a public speaker.
There are a number of devices and techniques commonly used by people with ALS that can support your breathing and improve the quality of your life. Talk with your healthcare provider before using the techniques and equipment shown in this video. You will see and hear an overview of several effective adaptations you can make if ALS affects your breathing. This video is designed to be used in conjunction with the ALS Association's Living with ALS Manual No. 6, Adapting to Breathing Changes. The ALS Practice Parameter provides recommendations for managing symptoms, including breathing problems. You will hear about the positive impact that non-invasive ventilation has been shown to have on survival and quality of life.
It's important to search for the symptoms, document them early, and then start them on non-invasive ventilatory support as soon as you can. Because of the fact that there is so much to offer, and that offering it early probably maintains energy, definitely increases lifespan, and at the same time decreases that further drop, that further decrease in lung volume.
Normally when we breathe, we don't think about it. It just happens. We take a breath in using our inspiratory muscle, and then we relax the muscle, and when we breathe out, it's passive. There's no muscles involved in it. The major inspiratory muscle is the diaphragm. There are also muscles in between the ribs called intercostal muscles that also work for breathing in or inspiration.
The air that you breathe in brings oxygen into the lungs where it is taken up into the blood. Carbon dioxide is released from the blood into the lungs and is eliminated when you exhale.
Expiration can sometimes be active, and there are two times that we can think about where active expiration is common is number 1 in talking and number 2 in coughing.
Weakened breathing muscles can lead to reduced ventilation and can interfere with the normal exchange of oxygen and carbon dioxide.
The diaphragm, being the major inspiratory muscle, when it gets weaker, we breathe more shallowly. And when we breathe shallowly, we also breathe faster. When the inspiratory muscles get weak, we don't sigh, we don't take a deep breath. When you sigh, you inflate your lungs to the full extent, and that prevents the lungs from having small areas of collapse. And in ALS, those small areas happen because the patients are not sighing. The lungs, when they have areas of collapse, get stiffer, and it's then harder to take a full deep breath. The third group of muscles that are involved in breathing are the upper airway muscles. You may hear of these as bulbar muscles. When these muscles are not working, a number of things can happen. One is that you can have trouble swallowing. And because of that, food can go, or liquid can go down into the lungs instead of into the stomach. And that's called aspiration. That can cause pneumonia. Patients with ALS often have trouble clearing secretions, and the only way you can clear them is to cough.
Activity and sleep both affect breathing. Respiratory muscles work harder when you exercise to meet the body's demand for more oxygen and to get rid of higher levels of carbon dioxide. When you sleep, muscle tone or strength is needed to keep your upper airway open. Your diaphragm works harder when you lie down because it has to push the abdominal organs down to expand the lungs. When you sit or stand, gravity helps move the abdominal organs down, which reduces the work of the diaphragm. As the respiratory muscles weaken due to ALS, breathing becomes more shallow and it can become harder to take deep breaths and cough. These challenges can lead to symptoms related to less oxygen and carbon dioxide moving into and out of the lungs, such as fatigue and sleep disturbances. Problems associated with respiratory muscle weakness can also include difficulties in keeping your lungs and airway clear of mucus and secretions.
We discussed some of the reasons why we recommend BiPAP. Yeah. And we talk about the fact that sometimes we recommend it when the breathing gets to the point where it's about half of what it should be, 50%, or if people are having symptoms of breathing problems.
What are the symptoms? They're really very simple. Shortness of breath with talking, shortness of breath with exertion, trouble lying flat to sleep, indicating that the diaphragm isn't working properly and needs the advantage of gravity.
You get severe headaches. You know, that was one of the things I had bad headaches. So it was all contributed because I wasn't getting enough air.
In terms of difficulty with breathing, patients will have a loss of respiratory muscle strength, just as they'll have a loss of any other muscle strength. And it's very important to separate out whether they're tiring more quickly when they're exerting themselves, more subtle things such as unable to really feel restored with sleep, awakening frequently during sleep, things that they would not identify as being shortness of breath, but may actually be symptoms of decreased vital capacity, decreased breathing reserve.
There are several specific things that you can do to protect your respiratory function. Discuss the following ideas with your healthcare provider. Get shots to protect you from the flu and pneumonia. Avoid close contact with people who have upper respiratory infections, and use good hand-washing techniques. Staying well-nourished and hydrated and planning activities to avoid fatigue can help conserve energy and reduce shortness of breath.
I'm going to show you how to hyperinflate John's lungs. So we're going to aid him in mobilizing some of these secretions, and then I'll show you how.
Where instead of the patient doing the cough, sort of on a hard, almost like a Heimlich maneuver, and that pushes the diaphragm up and helps the patient cough.
Faster.
Hold the mask firmly to prevent air leaks and coordinate the ambu bag breaths with the patient's own breathing rate. In addition to the quad or assisted cough, a technique called air stacking can be useful to help you take deeper breaths. Take in a series of 3 to 4 short breaths, one after another without exhaling. You are adding one breath on top of another to help you build a deep breath. Air stacking can be followed.
The thing that we can use is a cougholator. A cougholator blows air in and kind of sucks air out. And by doing that, you're mimicking a cough. So you're taking a deep breath, and then you're getting the air out very quickly, and that mobilizes secretions to come out.
Did you feel some of those secretions loosening in there?
The terms cougholator, encephalator, and cough assist device all refer to the same technique. The name of the machine that provides this treatment has changed with newer models. It is important that you and your loved ones be aware of the early symptoms of breathing weakness. Tell your physicians if you begin experiencing any symptoms described in this video. Your breathing should be monitored at least every few months by your healthcare providers. This may include 2 specific tests called nocturnal oximetry and forced vital capacity.
Okay, John, we want you to wear the pulse oximeter during the night. We'll show you how to put the probe on your finger. What it's going to do is measure your oxygen levels all through the night.
We're testing how many liters of air your lungs can actually hold and how much you can force out of your lungs. Deep breath in from your belly. Tight seal and blow out. Blow it out. Good, 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 good. Keep going, keep going, keep going, keep going, keep going.
Non-invasive ventilation, or NIV, is a treatment providing a flow of air that helps you take a deeper breath. Several different companies make NIV machines. One model is called the BiPAP, which stands for Bilevel Positive Airway Pressure. There are a number of different kinds of devices or interfaces that connect the tubing from the NIV machine to your nose or mouth. No invasive surgery, such as a tracheostomy, is required, and the NIV can be taken on and off throughout the day.
Mostly what we use are ventilators that apply air into the lung by attaching to the nose or sometimes to the full face, but normally we use the nose. And what that does is blow air into the lungs when the patient starts to inhale. It allows the diaphragm muscle, which is the major inspiratory breathing muscle, to not work as hard and to relax. And what we found is by relaxing that muscle and letting it work less, the deterioration in pulmonary function is much slower. The other thing that the non-invasive ventilator does, and BiPAP is one form of non-invasive ventilation, it can actually fully take over a patient's breathing should the patient stop breathing.
Make it easier for the patient to breathe and thus improving their quality of life.
There are two criteria. One is symptom and one is a number. The number is, of course, the breathing test, the vital capacity. When the vital capacity drops to 50%, we would recommend non-invasive ventilators. We would recommend them sooner if there were actually symptoms. I think that the first thing I like to do for patients is talk about symptoms, treatments, and differentiate treatments from cures. We don't have a cure for this disease, but we have a lot of different ways that we can really help patients with the disease and mitigate symptoms and prolong life in a meaningful way with high quality. And non-invasive ventilation really epitomizes this concept.
Benefits of non-invasive ventilation are many. The first one is that because of the fact that sleep disturbances are usually because of problems with breathing and frequent arousals, a better quality of sleep is pretty common. The second benefit that a person may experience is better energy, less daytime fatigue, less falling asleep during the daytime. Some patients experience a little more exercise tolerance, which is nice. Patients will often experience an improvement in appetite. They may experience a strengthening of their voice. They may experience a more explosive cough so that the cough is more effective.
We certainly want to look at whether or not it would be even more advantageous to start non-invasive ventilation at an earlier time point. Because if the mechanism by which it works is to reduce fatigue, and we start to reduce the fatigue earlier in the course of the illness, that may preserve lung function even more impressively than we've already demonstrated.
The non-invasive ventilator can slow down the respiratory muscle decline and weakness, because over time, the vital capacity, that breathing measurement we do in clinic, can slowly drop. And what we found is that using the non-invasive ventilator, that slope of decline levels off and is slower, and patients live a longer time when they use the non-invasive ventilator.
One of the things that we wanted to focus on is the decision-making process for people who are battling ALS, and one of the big decisions for you was about BiPAP or respiratory support. If you think back about that decision, was it the right decision?
I think it was the right decision, and I also think that we made it early enough that it had some serious benefits for me, because when we had to make the decision, I was still involved in work. I had a lot of activities that I did after work, and I was noticing that my energy level had decreased significantly. And so when I talked to you and Dr. Gelinas about it, I just said I needed something that would help me increase my energy. And she asked me how I was sleeping, and my sleep, of course, was being disturbed because I was having difficulty when I laid in the prone on how I was breathing. And so I wasn't getting any kind of a restful sleep. So she suggested a BiPAP. We discussed whether or not I should go on it this early, or whether I could wait until my capacity had diminished some more. And I thought about that, and I was tired during the day, and I was sleeping a lot sounder during the night, sounder than I'd ever slept before, really. And the wife even complained about it because nothing would wake me up.
I noticed that Rudy, another thing, he's not as tired. When he would wear it at night, he'd wake up and be headache-free, but then he would tire very easily, exhausted within a couple of hours. He would nap 4 to 6 times a day because he just needed to have that assistance. I see the benefits of him wearing it. He knows the benefits of him wearing it.
Mary Kay, you started non-invasive ventilation about 6 months ago now.
Yes, that's right.
And at that time, the indication, the reason we started it was your shortness of breath.
Right.
And you also were having some trouble with sleepiness during the day.
Yeah, very much, yes.
And since being on the non-invasive ventilator, has that helped at all?
It has. I'm not quite so short of breath. I can talk longer. Don't I, dear? Yes. And I think I feel better after I come off it in the morning.
Good. And so overall, your quality of life, what do you think's happened to it?
I think it's improved.
On a scale of 0 to 10, before you started the non-invasive ventilator, where do you think you were?
Probably 5 or 6.
Where do you think you are
and now I think I'm back up to 9.
Excellent.
Mm-hmm.
That's kind of statistics we like to hear.
Oh, good.
You like to know that you make a difference.
Yeah. Yes, I think it has made a difference.
You were just in clinic, I think, last week.
Yes.
And after 6 months on the ventilator, you started at 65% vital capacity, somewhere around there. What was your vital capacity?
It's 62, I think.
That's right. Actually, it was 68%. I looked it up.
Oh, it was? Oh, I didn't know that.
So
that's great.
So over 6 months, you basically have been holding your own on this machine. And typically, over a 6-month period, we would have expected maybe an 18% drop.
Oh, really? Oh, well, that is good news.
That is good news.
Yeah.
And we hope it continues.
Me too.
She had breathing problems, and she had the BiPAP, and I believe that she got quite good benefit from that.
Yes, she did. The BiPAP was really a godsend for the last couple months that she lived. She had had some episodes where she had difficulty breathing, and if we got the BiPAP machine and put it on her, it would give her enough oxygen that it would help her to breathe through those episodes. She did not use it most of the time. During the day, she was up, sitting up, watching TV, but whenever we would lay her down or put her to bed, she would use the BiPAP, and it seemed to give her a lot more breathing capacity in the reclining position. And I think it gave her reassurance that there would be something there in case she had a breathing problem during the night, that it would help her to get through that. So it was very helpful for us.
Well, it helps me sleep better. It keeps me from going to sleep during the day.
Non-invasive ventilation does not have to be used for 24 hours to be effective. We found that as little as 4 hours a day would have a significant effect on resting the respiratory muscles and slowing the deterioration. We've also shown that if you use it overnight while you're sleeping, 6 to 8 hours, that it has an even more beneficial effect.
This mask, it makes it 100% better. It took me about 6 or 7 months to get used to it. It's really important to use it and not fool around and skip 3 or 4 days. I can basically do just about everything that I want to do with this off. My quality of life is a lot better now. When it's prescribed to you, don't skip on it. Otherwise, it makes it harder to get used to.
I had some initial problems with the masks and the initial settings, but through the auspices of the pulmonary therapist, we worked on it and finally have it down now where I'm able to sleep comfortably long hours at night, where I was unable to do that before being on BiPAP.
It still goes more smoothly now than it did, before. Before, we probably would wind up just ripping the thing off and throwing it to the side, but we kind of really try to work with it now so that we can see, a difference.
He just took to it real well. He began to feel that he was feeling better by using it.
For me, I saw a different husband. One that wasn't struggling to breathe, one that wasn't waking up every day with severe headaches. We can go out and be gone all day long. As a caregiver for other caregivers, I suggest that you really support your loved one in wearing it.
How long does it take you to put it on, Rudy, and to adjust?
A minute, not even a minute, 30 seconds. We've got it down pat. We can get it going fast. Family and caregivers, support your loved one who needs to have some assistance in their breathing to wear it full time.
Then she wrote me a prescription for this thing. And that was about 3 years ago. I've been wearing it. I started out trying it out, watching TV for about an hour at a time. Slept all night with it, didn't bother me, so I was real fortunate.
But what I recommend is to have patience, maybe a day or two, and gradually get up to where you can use the BiPAP. And once you see, I want you to get 3 of them.
If you have weakness in your bulbar muscles, using non-invasive ventilation can be a challenge. The following hints and tips can help you be successful in using NIV. Work with your physician to manage your secretions effectively. Experiment with many different interfaces to find the best one for you that prevents air leaks. Begin using non-invasive ventilation early for short periods each day. And be patient. It can take time to adapt to this new treatment technique.
The other symptom you've been having has been secretion problems.
Yes.
Some of the ways we can manage that, we can use a suction machine, which will help you get at the secretions.
A suction machine can be helpful to remove secretions from the mouth and upper throat. A hospital bed can make your breathing easier by raising the head of the bed.
So the hospital bed will raise you up in the incline position. It makes it a lot easier to breathe.
An ambu bag is used in the air stacking and assisted cough techniques. It can also be used to provide ventilation for brief periods when you may be off of the NIV machine but need help breathing. A humidifier connected to the NIV machine can moisten and warm the air you breathe.
He was having nosebleeds before we used that, and the moisture and the warmth of the humidifier just helped that a lot.
It is not usually necessary to use supplemental oxygen since the challenge ALS presents is in moving air in and out of the lungs and not the exchange of oxygen and carbon dioxide.
The hose, as Larry has stated, catches on everything. But we've managed to place it where it's more comfortable for him. Also, every other day I wash this hose out, making sure that it is rinsed very, very well before he uses it again.
It was something new, of course, something for us, I guess, both to get adjusted to.
The better the interface or the mask fits not only with the face, but fits with personality, the more successful. Some interfaces don't allow you to wear your eyeglasses. If you need to wear eyeglasses to see, you're not going to like that interface. Some cover the mouth and the nose and can be relatively claustrophobic. If that's an issue for you, you're not going to tolerate that. Some people have a deviated septum in their nose and they really just don't breathe through their nose, or are terrible allergy sufferers and their nose becomes congested frequently. All of those things you take into account, and then if a particular interface really doesn't work, you switch, and there are so many different interfaces.
Well, the first thing they've got to do is get a person that is well versed in this to fit them with a proper facial apparatus.
Tell me what happened with your first experience with non-invasive ventilation.
It was a very uncomfortable experience.
Why didn't you stop trying?
Because you and many of the other good people at the clinic told me that this is going to do you some good. And so I decided that I had to do it, but I couldn't do it with the machine I had. And you said, okay, let's try something else.
Has there been any benefit that you've noticed?
Oh, yes, considerable. Yes.
Can you tell me about the benefit?
Muscle strength is greatly increased. General well-being.
We have a new one to show you now.
So what happens with this mask is that you put it on and it covers your whole face, but the nice thing is again, you can see through it. So I'll demonstrate this mask for you. Okay? Odd at first, okay, but most people really do find that it's quite comfortable because the whole mask breathes with them.
If caregivers are, if we're real honest, we can see a lot of things coming before they get. But the patient also has to be receptive, you know, and it's a two-way pull.
I started using the BiPAP, and at first it was a little bit uncomfortable, but I got used to it. It took me less than a week. You just learn how to breathe with it. But once you see the results, especially of getting a good night's
Evaporators on your face. Did you ever have the mask on your nose?
Yes, I started with a mask, but I found that the mask was giving me some pressure points in the forehead. So then I started asking and finding out other ways so I could alleviate the pressure points.
That's really important, is to get past the stage of you got something on your face.
And, you know, it comes no matter what your wheelchair setup is. There's always a way to mount it. His is in a backpack, just a school backpack is what we have his in. We go places if we know we're going to be gone at long periods of time. We have an extension cord and we plug it in so it doesn't run off of the wheelchair. But I see an increase in his stamina for the day by being on this. And I suggest it for, you know, for anyone.
Do you remember whether you felt hard to convince about this decision, or because my recollection is that you were pretty easy?
In this, I was because I was searching for things to keep me going. And so it really wasn't a decision about giving in, but it was a decision about continuing to do what I wanted to do, with whatever devices we could find to do it. So in this case, the BiPAP was the best decision for us. So I didn't mind doing that. I didn't see it as a giving up. I just saw it as another way of fighting this and not giving into it. And we're 7 years into this now.
I think decisions work best when everybody is involved. Making decisions is a very individual process. Some people, when they hear the evidence, which a healthcare provider will give them about a decision, say, fine, let's do it. Other people need a lot more thought and discussion about the process. And when that's the case, and it is the case for many people, we encourage getting more information, talking to people who've been through the process, reading about it, because the ALS Association and many of the local ALS centers have a lot of written material about it, and involving the family. Having a meeting just for the purpose of discussing these kinds of big decisions where key friends or family members and healthcare providers and caregivers are all present can really optimize a decision-making process and make a person feel right about the decision.
Well, the reason why I personally love non-invasive ventilation and why I think most of us in the field of ALS love non-invasive ventilation is that because it is a mask, you choose to put that mask on every day. Every day you make the choice so that a person who is on that type of ventilation clearly feels that the choice is his or her own.
Going on the BiPAP was a real good decision, and I've been on it now for almost 4 years.
You don't let this non-invasive ventilator stop you, do you?
Oh, I know.
Yeah, you've been pretty active.
Yes, we have.
Where did you travel recently?
Well, we went to Disney World. We went to Europe on a cruise. And I take my machine with me everywhere.
And it works.
And it works, right.
That's great.
We decided from the day he was diagnosed that we were partners in this and that we would listen to one another and help one another out.
It makes it hard for your caregiver because you have to understand you're not the only one going through this disease. Your family's going through also. The easier you make it on yourself, you make it on them.
You've heard that it changes the whole quality of life. Daytime fatigue is improved. Rest is improved. Shortness of breath is improved. You have more energy to do the things you really want to do.
Leave it on, you'll see the difference in your life, and we have.
If things become rough and it is no longer feasible to maintain your breathing, that you can elect to have a tracheostomy and be put on full-time positive pressure ventilation.
Did you ever think about a living will?
Yes, I did. And I've gone as far as drafted a living will to this point in my life.
Right.
I've given that a great deal of thought with my partner of 35 years, my wife, and I have expressed to her the desire, as I expressed to you right now, that once the BiPAP is no longer able to keep me breathing, that I would not consider going on a ventilator. And the reason, quite honestly, being very simple in my mind. I know this is a decision that a lot of people have to face. In my mind, it's a question of quality of life for both myself and for my family equally.
I just thought I wanted to try to make it as comfortable as possible and have as much time as possible to spend with my grandchildren, people that are on ventilators, and we tried to talk to them to see how things were and so forth, but for, I guess, the quality of life and the longer life and so forth, that people have been on ventilators for 4 or 5 years, even longer, and it extends their life, and that's what I was looking forward to. You still can get around, you still can breathe, I can still talk and so forth. I'm still able to enjoy life. I'm able to enjoy being with my family. It takes a lot of care that they have to provide and so forth, but on a daily basis, it's wonderful. I feel that I'm able to breathe a lot better than I did before.
Although the breathing problems described in this video are a serious challenge, there are ways to successfully manage these symptoms and maintain your respiratory function. By planning ahead and using the techniques and equipment presented in this video, you can improve both the quality and length of your life.
It can allow you to live a longer period of time, and all that's important, and give you more time to make long-term decisions about whether or not you want to be on a ventilator with a tracheostomy. Yeah. So we want to buy some time for you to make that decision, don't we?
We've had people who have been hooked up 24 hours a day over 2 years and never needed to go on to an invasive ventilator.
All I could think of was how to fight it. I don't think I ever had a thought of losing. It was just not something, I still don't think about that. I don't see myself as dying from this disease. So we can die from something else. This is not going to kill Kramer.
The ALS Association offers several free educational materials on breathing problems and non-invasive ventilation. Please contact us for more information and help in adjusting to problems with breathing. You're not alone in your fight against ALS. The ALS Association thanks the people with ALS, their families and healthcare providers who were the inspiration for this video and who welcomed us into their homes and their lives. This video, and others in the ALS Association's Living with ALS series, is provided without charge to patients and families, thanks to the generosity of our individual donors.